My name is Anne Mitchener. I'm a consultant neurosurgeon practicing in central London. Brachialgia is pain in the arm, and it is a pain that usually arises from the spine in the neck, the cervical spine. So, as with all diagnoses, we as doctors take a history of the pain. We examine the arm looking for signs such as weakness, numbness, and altered reflexes. And we inevitably request an MRI scan because that's safe to the patient, there's no radiation, and it gives us a very good definition of all the tissue structures. Some people can't have MRI scans and will have a CT scan instead, but we really need one or the other to look to see if there is something impinging the nerve. It's usually caused by impingement of a nerve leaving the spinal cord in the neck. And the impingement or compression of that nerve could be caused by a disc prolapse or herniation. It could be caused by ligamentous thickening, and the ligament is around the joints at the back of the spine and lines, to some extent, the spinal canal. And it can also be due to the facet joints at the back of the spine degenerating. We call it hypertrophy, and they tend to twist inwards and take up space in the spinal canal. Any or all of these things can contribute to compression of the nerve and cause the pain that's felt usually across the shoulder and down the arm. The treatment is one of 4 possible things. We usually start with simple analgesia. The patient has usually tried that before they come to see us. Sometimes the GP has prescribed neuromodulators such as amitriptyline or pregabalin. We usually try to combine the medication with physiotherapy at an early stage to see if that will help, as it's more conservative management without any intervention. Quite often when patients come to see us, the pain is severe and they're receptive to the idea of a steroid injection. And the steroid is injected around the nerve in the neck, and it's done in theatre to be clean, it's done with X-ray to be accurate. And most patients can expect a response with a reduction in pain within a few days after the injection. The alternative is to decompress the nerve surgically with an operation, but that's something we try to avoid and is a final choice. Surgery is very effective for this condition. As with anything, it is dependent on the right diagnosis and investigation and the right decision making before you proceed to surgery. But I'm struggling to remember a patient who's had surgery and not had pain relief in their arm. I really can't think of that happening. So it's highly effective if the need arises to actually decompress, and that can be done from an approach at the front of the neck or an approach at the back of the neck, and this is guided by the MRI images as to which would be the most appropriate.